Okay, good evening. So this is a continuation of our of my lecture in neuropathology. Okay, so in my previous lecture, we were able to discuss the common vascular problems involving the brain, mainly the strokes. Okay, so we were able to discuss the infarct, the cytopathology in infarct. Likewise, we were able to discuss the different vascular malformations that could lead to a hemorrhagic type of stroke. Okay, and we were also able to discuss the hemorrhagic infarcts and likewise the subarachnoid hemorrhage. Okay, so at this point, I'm going to discuss to you the pathology of central nervous system infections. So the brain and the spinal cord are protected by the three protective coats or meninges. The thin leptomeninges are the innermost coverings and consist of two distinct membranes, the pia, which is the one that's tightly applied to the surface of the brain and the spinal cord, and the arachnoid membrane, which is just external to the pia mater and is connected with the pia mater by these delicate trabeculae. And the space between the pia and the arachnoid membrane is called the subarachnoid space. So this space is filled with cerebrospinal fluid, and it is this fluid which is sampled when a spinal puncture is performed. Okay, so the surface blood vessels course in this space. So the term leptomeningitis or simply meningitis refers to an infection within this space, including, of course, involvement of the leptomeninges, which is the PNA in the arachnoid. So the outermost membrane covering the brain is much thicker than the leptomeninges, and it's called the dura mater, and it is tightly applied to the bones of the skull. So in addition to the leptomeninges and the dura, the bone coverings of the brain and the spinal cord and the skin forms the outermost defenses of the central nervous system. So what are the responses of the cell within the cord or within the brain when after a trauma? So the astrocytes, which is the most abundant glial cell, and the reticuloendothelial elements of the brain, or the microglial cells, are the two types of brain or cord cells which may respond in a non-specific manner to a wide variety of noxious stimuli, including infectious organism. So the microglia may simply proliferate while retaining their basic rod-like shape. So they usually proliferate via the process itself. It's called microglial activation, and it's usually this activated by an infectious process. Okay, so in addition, monocytes may enter the wound or the lesion and form macrophages, which carry away the necrotic debris. So the astrocytes, in response to this injury, may increase in their number, they may become larger and may increase in length and numbers of their processes, as what I have described in the previous lecture. However, the astrocytic process do not act well to wall off or impede the advance of the infectious organism. If you can still remember that the astrocytes sends soccer feet or process that maintains the integrity of the blood-brain barrier, or it covers the junction or the tight junction, or protects the tight junction between the cells the cells of the walls of the capillaries. Okay, and this would filter the substances that enter the blood-brain barrier, pass through the blood-brain barrier. So, however, this function of the astrocyte is not enough to impede or to stop the infectious organism. Instead, the fibroblast in the walls of the cerebral blood vessel may proliferate and may lay down collagen to form a wall around the bacterial invaders. Thus, abscesses within the brain can be walled off like abscesses anywhere in the body. Unfortunately, since these fibroblasts are not diffusely scattered throughout the brain, but are only present in the vessel wall, and since only other reservoir and since the only other reservoir of fibroblasts is the meninges, the wall of the cerebral abscesses may be less sturdy than the abscesses outside the brain. So the fibroblast that is located in the leptomeninges, okay, may also proliferate in response to the smoldering subacute or chronic infection of the subarachnoid space, and they can actually impede or block the flow of the CSF to the point that it would produce a hydrocephalus. So hydrocephalus may also be produced by ventriculitis, which is the inflammation and necrosis and desquamation of the ependymal cells at the level of the aqueduct of Sylvius. So therefore, the hydrocephalus that we see in patients with with meningitis is brought about by the blockade of the flow of the CSF through the leptomeningeal fibroblasts, then produce in all cause, and of course the desquamation of the ependymal cells within the ventricles that blocks the CSF flow. So that's why they develop hydrocephalus. So with meningitis, you have purulent reaction, and this is characterized by polymorphonuclear cells mixed with fibrin and bacteria. So the great abundance of the neutrophils and imparts a characteristic creamy yellow-white appearance of the pus, which forms the center of the abscess and fills the subarachnoid space in meningitis. So this is a picture of a brain that is or I mean, this is the picture of how the purulent reaction after meningitis, okay? So you see, makita mo lang talaga all inflammatory cells, polymorphonuclear cells, and likewise fibrin, and sometimes the causative agent or the bacteria. So this is a picture of a patient with severe meningitis, or a brain with severe meningitis, rather. So note the creamy pus completely obscures the underlying cortex and in the brain, or in some areas of the brain. So the pus also tends to collect in the cisterns at the base of the brain, and simply because that the pus are as much heavier, higher density than that of the CSF, so that the pus would go down and then collect at the base of the brain. So the purulent meningitis is by far the most common CNS infection. So let's talk about brain abscesses. So the incidence of brain abscesses has been markedly lowered since the antibiotic era. As would be expected, they are found more frequently in the individuals who are susceptible to general infections, such as those diabetic patients, alcoholic, immunosuppressed, and debilitated patients, and likewise the elderly. They are also noted with increased frequency in infants with cyanotic heart disease, because remember, in patients with cyanotic heart disease, if they develop vegetations in the blood vessels, it can form an emboli of microorganisms that would go to the brain and then later develop into abscess. So brain abscesses are most frequently caused by Staphylococcus, Streptococcus, or pneumococci, and the primary infections are usually located in the sinuses in the ears, likewise in lungs, and then in the heart valves. So this picture shows the basic structural features of a brain abscess from a histologic point of view. So it has three areas. We have the A, B, and C. The A is we call the purulent or the necrotic center. This is the, um, the center of the abscess. And then we have a thin zone of granulation tissue. And then you have, and then the most outer part is the collagenous connective tissue capsule of the abscess. Okay. So this is a CT scan of a patient who have a cystic mass in the frontal paramedian area, and it's a big mass that is cystic in nature. You see the mass has a capsule that surrounds it, and therefore this must be a a, a an abscess. Okay. Now, if post-mortemly, when they took the brain, they cut it into slices. Of course, the fluid was taken out, but and then the abscess collapsed, and this is how it looks like. But then what I'm trying to show here is that this is the capsule of the abscess. You see the capsule, then you have this with the purulent necrotic center. Okay, but then of course the most outer portions of the capsule you also see here a surrounding edema. Okay, over here. So suppurative meningitis has three different phases. It can be acute, subacute, or chronic phase. So during the acute phase of the suppurative meningitis, what we're going to see is pus in the meningitis, in the meninges, first in the subarachnoid space, especially in the virtual Robin space. And only that, because there's active inflammation, you see also cerebral edema. In the subacute phase or the chronic phase, what you usually see if you do microscopic examination of the tissue would be presence of fibrin and then presence of mononuclear cells. Okay, then you can also see vasculitis and then thrombosis and likewise infarction in the brain tissue. And likewise, since it's a chronic inflammation already, then you'll develop fibrosis. Okay, so this is a picture of a patient, of a brain rather, with suppurative meningitis. See uh, the pus covering the whole brain. Okay, so this is a suppurative meningitis. Also, if you get pick a piece or a part of it, and this is what you see. So let me just orient you. This is the brain, no? And then the brain tissue, and then this is the Robin Virchow's area, no? Or space. You see this is the subarachnoid space. So you see a lot of inflammatory cells in the subarachnoid space, and likewise there is um, cells also all throughout, a lot of polymorphonuclear cells also scattered within the brain tissue. Okay. Normally, the CSF is acellular, and then of course, if you see inflammatory cells, and therefore this is a case of a meningitis. At high power field, you see, you have a lot of inflammatory cells, and likewise you see phagocytes, okay, or it can be monocytes. So here in this is a brain in a coronal section. Coronal section, yeah. And then what I'm trying to point out here is the presence of pus also within the ventricles. And this would mean that there is a concomitant ventriculitis, okay? And which is of course seen also in patients um, with supportive meningitis, okay? So this is the, you know, the um, or the cytopathology or the morphology, or the tissue. They took a tissue of the brain tissue along the ventricles. You see, this is the linings of your ventricles. Normally, what you see would be columnar cells, ependymal cells, and then normally they should be clear. But now you see a lot of polymorph or nuclear cells or inflammatory cells. Therefore, this is a patient. This is a brain with ventriculitis. Okay, some of the linings are now desquamated, so that would add up to the that would lead also, if it would stop into this to the narrowest area of the ventricular system, then could develop a non-communicating hydrocephalus, or a communicating hydrocephalus, a non-communicating hydrocephalus rather. Again, low power field, you see that this uh, you see also in the tissue a lot of polymorphonuclears, meaning there is also infiltration of the inflammation, or there is also inflammation of the brain tissue. Okay, this is suppurative meningitis with ventriculitis, and these. Look at this, siguro napakita ko lang dito is that there are a lot of polymorphonuclear cells, and likewise large monocytes and phagocytes. Okay, so this is a picture, of course, of a brain with suppurative meningitis. What I'm trying to say, to show here, is that uh, the pus could accumulate, or usually settles down at the base of the brain. If the pus goes down here, okay, just like here, hindi mo na ma-appreciate, you can already appreciate the brainstem and the cranial nerves because it's covered with pus. With this, you can have inflammation of the cranial nerves, and of course, usually the manifestation would be cranial nerve palsy, especially in the early stage of suppurative meningitis. Usually, the patient will manifest with diplopia, or it is because of this mechanism also, on top of the raise in the cranial pressure. So see this one. This is a brain stem. Now this is the base of the brain. You see this blood vessel over here. This is the vertebral artery, and it unites to become the basilar artery. This is the pons, and then of course this is the cranial nerve. You see a thin film that covers it. Now that this is pus. Okay, so this the slide. Napakita ko lang to, it's because I just want to show that inflammatory cells, or pus, usually accumulates in the base of the brain also. So another picture here with a coronal section of the brain. Pinapakita ko lang dito that this is pus. Okay. Next, so this is a picture of a blood vessel. These are smooth muscles over here, going around, and then it looks like that there is inflammation. You see a lot of polymorph nuclear cells here. So therefore, this is a blood vessel that is inflamed. So this is vasculitis. Okay. However, what's a problem with vasculitis, when the blood vessels are swollen, the flow of blood is also sluggish, and that's why they form clots. And then you see the lumen, maliit lang yung lumen ng blood vessels, and then you can develop infarcts. Okay. So we're done with the CNS infection. Let's go now to multiple sclerosis. So multiple sclerosis is a demyelinating disorder, which is very common among females and usually seen in mid-aged women. Um, um, the manifestations would be a lot. There's a lot of manifestations that depend. The manifestations will depend on to what areas of the brain that is, or the tracts that are involved. For example, it involves the corticospinal tract, and therefore the patient would have, if the demyelination is in the corticospinal tract, then the patient would have weakness. If it involves the optic nerve, then you can have optic neuritis. Or if it involves the sensory nerves or the sensory tracts, then you're going to have sensory deficits. So it is a demyelinating disorder now, and there are several types. It could be progressive, it could be waxing and waning type. Okay. So the pathology in patients with multiple sclerosis is that it's demyelinating, but the axonal injury is also very important. Okay. Um, but normally it's the myelin of the nerves in the central nervous system is usually affected. It only affects the central nervous system. It does not affect the peripheral nervous system. The reason is unknown, but probably it reflects a different antigenic makeup of the peripheral versus the central nervous system myelin. So the preservation of the axon is relative, but important in progressive disease. They have found out that those types of the progressive type of MS or multiple sclerosis, there is usually there is already involvement of the axon. And the lesion of myelin loss with the relative axon preservation is well circumscribed and is called a plaque. So on gross inspection, the plaques are circumscribed, gray or translucent, and they're often juxtaventricular near the ventricles. So this is a specimen wherein they stain it with a myelin stain. Okay, the plaques are usually unstained zones, okay, of pallor. So pag stain ng myelin, hindi siya na stain. So that's why it's called it's lighter. Okay, so the oligodendroglial cells also are markedly diminished within the plaque itself. Okay, so diminished yung, and so how a that's how you show or you uh, examine a plaque by doing myelin stains. So the plaque is also recognizable in gross brain as a well-circumscribed zone of altered color and density. So yan yan. Okay. So yung itsura niya. Usually located in the juxtaventricular area. Okay. So let's talk about Parkinson's disease. Parkinson's disease is a neurodegenerative disorder that affects the motor system, and usually it is manifested with a triad of bradykinesia, resting tremors, and then cogwheel rigidity, and likewise uh, um, balance problem. Okay, so this is a specimen of a midbrain. Okay, so in a normal adult, the substantia nigra, which is this one, is located the posterior portion of the crus cerebri in the midbrain, and usually it is pigmented. No? The pigment in the substantia nigra is dark, no, and because of the presence of the brown melanin in the neuron. If you can still remember that this neuromelanin is a byproduct of the catecholamine metabolism. Okay, the dopamine and then the so example the dopamine and um, so they're usually seen in the neurons of the substantia nigra. Okay. So there is more than one cause of the nigral degeneration. So what happens in Parkinson's disease, there is nigral degeneration. Hence, more than one cause of Parkinson's disease. And the two causes considered most common is viral encephalitis and the unknown or the idiopathic uh, cause. So most newly discovered cases of Parkinson's disease are idiopathic. However, it is now known that patient may have abnormalities in the gene for the protein called Parkin gene. So Lewy bodies in this image are also one of the tawag dito, um, pathological findings we see in patients with Parkinson's disease. Not only in Parkinson's disease, also in Lewy body dementia. So Lewy bodies are intracellular, intracytoplasmic eosinophilic inclusions with clear halo. And then you see this in patients with Parkinson's disease and also in Lewy body dementia. So in addition to the presence of Lewy bodies, so Parkinson's disease is characterized by the degeneration of the nigral neurons with liberation of the neuromelanin into the adjacent tissue where it is phagocytosed and carried away by the macrophages. That's why it loses its um, its pigmentation. So these results not only in the destruction of the dopamine factory, but also in the depigmentation of the substantia nigra. Thus, in a patient with well-developed disease or a fulminant disease, the substantia nigra is pale and no longer stands out like a dark band in a normal brain. So this is a normal midbrain with the well-stained or darkly stained substantia nigra. In this patient, this is an abnormal patient with Parkinson's disease where you already have diminution in the pigmentation of the substantia nigra. Okay, due to the destruction of the nigral cells that contains or neurons that contains neuromelanin. Okay, so in the microscopic image, you see loose pigments liberated from the destroyed neuronal cell bodies. Is seen as the brown granular clumps of neuromelanin between the intact. So this one that is located outside each neuron. So these are your neuromelanin from a deceased nigral neuron. And then later, this will be phagocyte host by the macrophages. That's why in patients with Parkinson's, they lose their pigmentation at the substantia nigra. So Lewy bodies and the other changes can also be seen in the leukoceruleus, where norepinephrine rather than dopamine is produced. So the brown pigments found in neurons of the normal leukoceruleus results from the degeneration of norepinephrine rather than dopamine. So in the picture here, the brain stem of two patients are shown at the level of the anterior basis pons or in the level of the pons. Just below the latter, the lower corners of the fourth ventricle, the darkly pigmented leukoceruleus can be seen. So in here, you have this is the fourth ventricle, this is the leukoceruleus. Okay, and then in patients with Parkinson's disease, it loses its pigmentation. So because therefore, patients with Parkinson's disease does not only nilang nawawala yung neurons that contains dopamine, but also those neurons that produce this that contains norepinephrine, which is the leukoceruleus. So let's go now to the developmental disorders of the central nervous system. So congenital malformations are anatomic abnormalities present at birth. Okay, they may be macroscopic or microscopic. About 15% of death in the neonatal period are due to congenital malformations, and about 6% of 1-year-old infants have congenital anomalies. So malformations of the nervous system are expressions of arrested or perverted prenatal development. So there are two main hypotheses that you consider as the cause. The one is induced in utero or a programmed by genetic defects. Um, Induced in utero, so abnormal metabolic or nutritional states during pregnancy, toxic agents or infectious agents such as your measles or rubella virus are may cause this. Okay, a malformation. So radiation effects like X-ray or atomic explosions, and faulty implantation of the fertilized ovum are also considered uh, teratogens. Okay, so the abnormal metabolic nutritional states, and then other teratogens that is wherein the baby was exposed to while in uterus. The second is programmed by genetic defects. So these results from a complex interactions of genetic and environmental factors. So often these abnormalities takes place in the early fetal life, probably in the first trimester. So each organ has a critical period during which its development may be deranged. So you have to know the different the organ system development, no, during in utero. Okay, so kailangan alam mo yan. So, like for example, during the first 2 weeks of development, teratogenic agents may kill the embryo and may cause chromosomal abnormalities or cause chromosomal abnormalities, which give rise to congenital malformations. Okay, so since usually the first 2 weeks when neural tubes pa lang na develop, then if the baby is exposed to these to teratogenic agents at that early on, the, the embryo may die. So during the 13 to the 16th day of pre-up day period, teratogenic agents may cause major congenital anomalies. Okay, and then from from 9 weeks to term, little damage can be produced to the fetus by most of these agents. However, intrauterine infections like toxoplasmosis may still be able to produce congenital defects even late in the intrauterine life. So, what are the common congenital anomaly? Number first is the anencephaly. In anencephaly, this occurs in 1 per 1,000 birth, and there is no closure of the anterior portions of the neural tube or the neural groove. You can still remember during development, if I remember, you have a neural tube, deposit closes from the middle, and then it goes anteriorly and it goes posteriorly. So if there's no closure of the anterior portions of the neural groove, then you'll develop an encephaly. So the vault of the skull is usually missing. The cerebral hemisphere, the diencephalon, and the meninges are not developed and are usually represented by an exposed mass of undifferentiated vascular and dysplastic neural tissue. So note the failure of the development of the skull also. So instead, there is an amorphous mass of soft vascular connective tissue mixed with glial tissue. So sometimes no neural elements are identified within the structures. And this is not, of course, compatible with life. Okay. Usually die within 24 hours. Next is encephalocele. Okay, this image above is a case of a cranial encephalocele or a meningoencephalocele, which is attached to the occipital area of the skull. Okay, anterior or other presentations may occur, but is less frequent. You can have also an anterior meningoencephalocele or encephalocele. So this condition occurs about once in 2,000 births, and in encephalocele there is herniation um, of the brain into the sac lined by the meninges and the skin. Okay, so encephalocele. Another normality could be a hydrocephalus. So this picture here is due to shows of dilated ventricles, and of course the temporal horns of temporal horns of the ventricular system, which is usually closed, it's now open. So this is a patient with hydrocephalus. So what could have been the cause? Would be congenital. Maybe the outflow of the CSF was blocked. Okay, it's blocked. So here, one important cause would be an aqueductal stenosis. So this congenital defect is a frequent cause of hydrocephalus, and in addition to being a congenital defect, it may be acquired later in life, for example, as a result of an infectious process, like, for example, rubella. Okay, rubella can cause aqueductal stenosis that could result to hydrocephalus. Next is Arnold-Chiari malformation. Arnold-Chiari malformation is really a collection of defect which may vary somewhat from case to case. So usually mayroong Chiari malformation 1, 2, 3. Okay, so commonly hydrocephalus is found in patients with Arnold-Chiari. Likewise, aqueductal stenosis will also be present. In addition, many cases of Arnold-Chiari have a displacement of the brainstem, and the cerebellar tonsil tissue is pushed downward through the foramen magnum. So in this case here, you see this is the brain, this is the brainstem, and like as you see the cerebellum, and this is the foramen magnum. So normally you don't see the cerebellar tissues here below the foramen magnum, but here you see merong cerebellar tissue that goes beyond the foramen magnum. Okay, and likewise the tonsils of the cerebellum is even inferior to that. Okay, and then you also see a kink here in the cervical cord. Okay, so the image here illustrates the brainstem and the cerebellum cut sagittally in the case of an Arnold-Chiari malformation. So the arrow points to the cerebellar tonsil or pegs of the cerebellum, which may have been displaced caudally over the roof of the medulla. So this is normally you only see this at the level of the pons. Ito nag-move pa siya beyond that. Okay, so this is an example of an Arnold-Chiari malformation. Meningomyelocele, they develop alone from the failure of the posterior neuropore to close. If it is anterior neuropore, usually it's an anencephaly, but if it is posterior neuropore, usually it is myelomeningocele. This failure has been associated with maternal deficiency of folic acid early in the pregnancy. That's why we usually give folic acid supplement to a pregnant woman. So if the dura and the leptomeninges, chiefly the arachnoid, protrude through the defect in the bone, the sac is created called meningocele. A meningomyelocele or a myelomeningocele occurs when the neural elements such as the spinal cord or the nerve roots and the nerves protrude into the sac. Pero pag walang neural tissue, it's called meningocele. If pag merong neural tissue protrudes with it, it's meningomyelocele. So these are the types of spina bifida. First is the spina bifida occultor. There's no closure of the bone at the back. However, you only see tuft of hair, which is called hypertrichosis. Okay? Pag may buhok kayo sa likod, in the inferior portion of the lower back, magpa-x-ray na kayo. Para you have spina bifida occulta. Second is meaning usually they have a normal neurological examination, so walang weakness. Second is the meningocele or the meningocele. So you see here that the sac only contains this protrusion, and the sac only contains the meninges. So we call it meningocele. If the neural tissue goes out like the spinal cord, it's meningomyelocele. If in severe forms where hindi nag-close talaga yung tissue and expose yung tissue, you call it rachis. Okay. Again, is one way of showing the side view naman. So this is spina bifida occulta with the hypertrichosis here. You have meningocele wherein the sac doesn't contain any neural tissue, and then this is your meningomyelocele. Usually this is associated with Talipes equine virus or abnormalities in the lower extremities. So common tumors. So the incidence in percentage of more important tumors of the brain parenchyma are: number one, the most common is glioblastoma multiforme, and then astrocytoma, which accounts for 20%, ependymoma, 6%, oligodendroglioma, which is 5%, and medullostoma, which is 6%, and the others, total of 100%. Astrocytoma are largely tumors of the adult, but are still the leading primary brain tumors in children, including the glioblastoma multiforme, which is, of course, the grade 4 astrocytoma, which is the malignant form of astrocytoma, or yeah, they account for about 75% of all the tumors arising in the brain parenchyma. So these tumors can be found anywhere in the central nervous system. So astrocytomas. So astrocytomas, these tumors can be found anywhere in the central nervous system, but are most frequently seen in the anterior half of the cerebrum in adults. And in children, it's usually the posterior foci and hypothalamus. Okay, so some of more slowly growing astrocytomas, the grade 1 or grade 2 astrocytomas, may permit survival for several years, whereas patients with glioblastoma multiforme, which is grade 4, and aplastic astrocytoma, which is grade 3, usually die within a year following the surgical decompression of the tumor. This, even with surgical decompression, it has a high mortality rate. So grossly, there is poor demarcation of astrocytoma from the surrounding parenchyma. It is difficult to define where the tumor ends and the normal tissue begins. All that may be seen is enlargement of the involved portion of the brain and the loss of the distinction between the gray and white matter. So you see it here. You see it's not, it's, you see the lumaki yung size niya, pero you can see the demarcation, and you also see normally you have a gray and white matter interface, pero ito wala. Nawawala yung gray and matter, gray and white matter distinction. However, the higher grade astrocytoma are usually strikingly visible, since they may show marked necrosis and discoloration like in glioblastoma multiforme of the frontal lobe. Usually, if you see necrosis, that would only mean the astrocytoma is grade 4. Okay. Note that the tumor is infiltrating in the corpus callosum and crossing over the opposite side of the brain. The tumor cells will be seen microscopically even in the areas about the tumor which appear grossly normal. So dito makita mo wala namang tumor, pero most likely may cells because nawawala na yung gray and white matter distinction. But probably it has already extended here. You see that the tumor also extends on the opposite side of the brain through the corpus callosum. Normally, the corpus callosum is thin here, but it's bulky here. It's more diameter is wider. So normally, ano lang siya, small, thin lang siya. So therefore, you see a tumor on this side, and likewise a tumor also on the opposite side, and we call that the butterfly lesion. If you see that, most likely it is glioblastoma. So the grade 1. So what is grade 1 astrocytoma? Here, the only unusual feature encountered may be an increase in cellularity. Marami lang yung astrocytes. So if you see hypercellularity, okay, that's grade 1. Here in the image here, there are too many astrocytes for a normal brain, but the cells themselves have the appearance of a normal astrocytes with uniform oval vesicular nuclei and a fibrillar cell process. Fibrillar cell processes, the astrocytes still look normal here. Okay. So the cystic cerebellar astrocytoma should not be confused with hemangioblastoma, another benign cystic tumor of the cerebellum. So it should not be confused by cystic cerebellar astrocytoma or pilocytic astrocytoma. Pilocytic astrocytoma is a common cerebellar tumor of the adult. It's usually uh, astro, uh, astrocytic by origin. Okay, so common yan sa cerebellar. Remember, I've mentioned that the astrocytoma in adult is more commonly seen in the anterior portions of the cerebral hemisphere, while in children it is more common the posterior fossa in the brains that were in the cerebellum, and usually it is pilocytic, cystic. So the image here displays the brightly eosinophilic crescental fibers and the eosinophilic bodies in a slowly growing astrocytoma. So in slowly growing astrocytoma, you see these eosinophilic crescental fibers. If you see this, most of the time, the tumor, the astrocytoma, is a grade 1 or a slowly growing one. So pathologists in training should know that the peloid astrocytoma may have a highly pleomorphic areas and even display some vascular hyperplasia, normally a sign of a higher grade malignancy. But in this setting, and especially with the hint provided by the horizontal fibers, the presence of pleomorphism and vascular hyperplasia has no significance. So kahit how marami pa siyang magiging hypervascular pa siya, probably if you see this, most likely it is a slowly growing astrocytoma. Now we will discuss the feature which indicates rapid growth potential astrocytoma, which is the grade 3, grade 4 respectively, named by most pathologists as the anaplastic astrocytoma and glioblastoma multiforme, respectively. So the most common important criteria will be the appearance of the nucleus. Atypical nuclear changes are shown in the plastic astrocytoma in the image here. You see this one, look at this, there are multiple nuclei and a bizarre looking nuclei. So that is means that most likely this is an aggressive tumor. There is extreme pleomorphism of these large, irregular, dark, bizarre nuclei. Often this pleomorphism is so extreme that giant cells can also be seen in patients with aggressive type of astrocytomas. Another indication of malignancy is a vascular proliferation. So endothelial proliferation of a vessel in glioblastoma is seen in this image here. So you see this blue one, these are your blood vessels. And if you see a lot of blood vessels there, then most likely it shows hypervascularity, and it means that this is most likely an aggressive or a malignant form of astrocytoma. One might think that vascular hyperplasia improves nutrition of the tumor, but in fact, the lumen are so small that this contributes, along with an increase in the total vascular length, to an increase in vascular resistance and probably to decrease blood flow in the tumor. So hypervascular, marami silang blood vessels, pero these blood vessels are inefficient. So one might even speculate that this contributes also to the necrosis, which is characteristic of grade 4 astrocytoma. So note here the irregular necrotic central area surrounded by palisades of tumor cells. Okay, palisades of tumor cells. This is called pseudopalisading, which we see in patients with glioblastoma multiforme. So much of the necrosis is presumed to be due to the fact that the tumor is growing so rapidly that it has outstripped its blood supply. So we're done with astrocytoma. So again, you have four types. We have type 1, type 2, and then type 3 and type 4, which is, of course, your anaplastic and the glioblastoma. Okay, the type 1, I think, is fibrillar. Uh, okay. So the type 2, just look it by, hanapin nyo na lang. So meningiomas. So these tumors accounts for approximately 15% of all the intracranial neoplasms. They have their greatest incidence in the middle age and in women. However, they occur at all ages and are common also in men. But more mas maganda yung sa taas yung incidence dito with the women. I only see one so far. Nakita ko meningioma from one in my training sa lalaki at saka sa in my practice here. But the meningioma yung nakita ko sa dito is in the spinal cord. So the meningioma is almost always benign, though aggressive examples are sometimes encountered. Malignant transformation occurs very, very rarely. But I also saw one case of this. No, di ko malipatan yung oncologist namin sa UST died because of this malignant meningioma. Oncologist pa siya. The majority of these tumors arise from the arachnoid cells in the dura mater, and particularly in areas adjacent to the sagittal sinus, the sylvian fissure, and the bony ridges of the base of the skull, and they compete with schwannomas as the most common tumor in the spinal canal. So others may sometimes arise in the leptomeninges and in the ventricles. Okay. So keeping with their benign nature, the meningiomas on gross inspection are well demarcated. Okay, they're usually well demarcated and they tend to push into but not invade the brain and frequently can be excised. So the symptoms of patient with meningioma usually is due to the compression of the of the brain tissue because of their size. It is a very slow, it's a slowly growing tumor that sometimes you won't even notice until nang isang parang itlog na siya kadako na it compresses significant parts of the brain. Okay? Nagka-complain. It was usually very minimal yung headache because it's a slowly growing tumor. Histologically, sheets of plump, uniform, meningothelial cells are seen, which have a marked tendency to form whorls. These whorls may degenerate and mineralize to form samoma bodies. So these are your samoma bodies. That is why if you have cranial CT scan and then you have calcification, no? in a mass with calcification, think of meningioma, okay? Because it is because of the presence of the samoma bodies that nagka-calcified yung samoma bodies. So that's why when you do the cranial CT scan, it appears a calcified mass. Next is schwannomas. Schwannomas or neurilemomas make up about 7% of all intracranial neoplasms. Most meningiomas have their highest incidence in middle age and in women, like meningiomas. So women din sila middle age din, but they are rarely malignant. So the gross appearance is also much like that of a meningioma, except that the cut surface often shows small areas of hemorrhage and discoloration. So these nerve sheath tumor are seen most frequently in the 8th cranial nerve and as an acoustic neuroma, in which case they occupy the cerebellopontine angle. No? If large, they could greatly distort the cerebellum and brainstem. So normally, pag acoustic neuromas lang, hearing impairment lang, but if it's large enough, since the location in the cerebellopontine angle, you can have ataxia or incoordination. So clinically, patients may present with deafness and tinnitus on the affected side, as well as ataxia if it's great enough to compress the cerebellum. Identical nerve sheath tumors are also seen in the spinal roots and in the peripheral nerves. Histologically, the tumor is made up of sheets of uniform spindle cells. some of which are forming palisades called the Verroque bodies. Okay, so I think Verroque bodies, spindle cells, no? Sheets of spindle cells in your Verroque bodies. So these cells resemble a normal Schwann cells. In addition, a foamy reticulated tissue is sometimes seen in these tumors, which may represent the generation of the cell just of the cells. So the dense spindle areas are known as your Anthony A, okay, this one, and then the looser one, which is called the Anthony B. So the looser ones are usually Anthony B. The one that has first of all talaga dense in spindle areas. Yeah, that's Anthony A. Next, neurofibromas. So these peripheral nerve tumor resembles a schwannomas and are differentiated from the latter by histological criteria that are not always distinct. As a rule, however, neurofibromas are less cellular, okay, and lack striking palisading uh, of the cells and are more loosely packed than schwannomas and may have much more striking collagenous components, more red bundles. Yeah, okay, so in about 10% of the cases, neurofibromas may become malignant. So multiple neurofibromas are seen in von Recklin's disease or a familial disorder, also characterized by pigmented spots in the skin, which we call cafe au lait spots. So the von Recklinghausen's disease is often associated with multiple meningiomas, schwannomas, and glial tumors within the cranial cavity. So Alzheimer's disease. So Alzheimer's disease is one of the most common cause of dementia. It is generally considered to be a major dementia in America. In fact, it is characterized by atrophy and the microscopic presence of senile plaques and neurofibrillary tangles. So this is how a demented or a demented brain looks like, or a brain with Alzheimer's disease. You see there is brain atrophy. The mas deeper yung mga sulci niya, tsaka yung gyrus niya much thinner. So this is a brain with generalized atrophy. So what you also see in patients with, ano makikita natin in patients with dementia, you can see senile plaques, which is a neuritic type, no? And they usually use the Belchowski stain to stain this, and they usually stain black, no? Normal accents usually stains black. So the plaque contains dark black swollen distorted accents or dendrites, and these distorted processes are called neurites. All of these are neurites. So electron microscopy show them distended shows them distended by a variety of the debris. So that's how a neuritic or senile plaque looks like. So in here, so pag low powerful, this is how it looks like. So marami sila. Okay. And then, okay. So that's how a neuritic plaque looks like. And then, of course, as we've mentioned before, in patients with dementia, you also see neurofibrillary tangle, and usually stained by Belchowski silver stain. This is how it looks like. Okay, this is your neurofibrillary tangle. This is neuritic plaques. This is a neurofibrillary tangle. Okay, remember that from from the cell body, you develop acetylcholine, and then of course, and then this acetylcholine is transported to the terminal butons of the axon. Okay, for release. In patients with Alzheimer's, this neurofibrillary tangle um, um, disrupts the transport of acetylcholine to the terminal button. That's why there's lesser acetylcholine and then causing a cognitive decline. Of course, other substances that are seen in Alzheimer's disease is the hirano body. So here is your Hirano body. So can be intracellularly or extracellularly. Intracellular and extracellular. So these are your Hirano bodies. Okay. That's all. And I'm done. Thank you.